SmithKline and French Laboratories is pleased to bring you another edition in the series Eating and Sexual Disorders, highlights from the 6th Annual Vail Conference of the Menninger Foundation. Dr. Jon K. Meyer, professor of psychiatry in the Department of Psychiatry of the Medical College of Wisconsin, begins this program with a discussion of male sexual dysfunctions. First, here's a brief message from SmithKline and French Laboratories and SK&F Co.
Gradual release action is the only major advance in lithium therapy since the discovery of lithium for the treatment of manic episodes in manic depressive illness. Consider the benefits of Escalith CR, brand of lithium carbonate, the controlled released 450 milligram tablets from SmithKline and French Laboratories. Escalith CR therapy diminishes the serum level peaks and valleys associated with conventional immediate release lithium medications. The 450 milligram tablet strength of Escalith CR may make it simpler when you want to switch patients from a TID to a BID dosage regimen. Finally, BID dosage with Escalith CR encourages long-term therapeutic compliance, an important advantage given the grave implications and mounting statistics on noncompliance. If you are not familiar with the benefits of gradual release action, we hope this message encourages you to consider the use of Escalith CR 450 milligram controlled release tablets for your manic depressive patients with a history of mania.
Lithium should generally not be given to patients with significant renal or cardiovascular disease, severe debilitation, dehydration, or sodium depletion, or to patients receiving diuretics. Lithium may cause fetal harm when administered to a pregnant woman and is not recommended in children under 12. Lithium toxicity is closely related to serum lithium levels and can occur at doses close to therapeutic levels. Facilities for prompt and accurate serum lithium determination should be available before treatment is begun. Patients should be cautioned about activities requiring alertness. Before prescribing Escalith CR, please consult the accompanying complete prescribing information, including warnings, precautions, and adverse reactions.
If you have any questions about Escalith CR, we invite your inquiries. Please write to the Medical Department, SmithKline and French Laboratories, Post Office Box 7929, Philadelphia, Pennsylvania, 19101. That's Post Office Box 7929, Philadelphia, Pennsylvania, 19101.
Now, here is Dr. Jon K. Meyer speaking on male sexual dysfunctions.
If the child is the father of the man, and if there are problems in their formative years, then there has to be some consequence for psychosexual development later. In general, those syndromes that are pre-Oedipal in origin, that is, that the child has had unfortunate environment or has made very little out of what available environment he had, such that there are signs of disturbance showing very early, so that we can call those pre-Oedipal syndromes, one tends to see either loss of sexual function or a perversion of sexual function. In the Oedipal syndromes, that is, the children who begin to show disturbances somewhat later on, when many of the major psychic functions and psychic apparatuses are pretty well put together, you don't tend to see as much difficulty in sexual syndromes that grow out of trouble at that stage. What you see tends to be impairment of pleasure and satisfaction rather than loss or perversion of it. To give you some examples, some pre-Oedipal syndromes, I think, are the gender disorders, the severe paraphilias, and such things as primary impotence. Oedipal syndromes tend to be things like obsessional premature ejaculations and hysterical anorgasmias, that is, impairment of pleasure but not loss of function. The capacity for sexuality and sexual identity and the broad constraints within which that capacity or capacities will operate are the legacy of fetal life. But the development and expression of sexuality and sexual identity are, I think, in the trusteeship of postnatal development. In males, the two commonest disorders in our 12 years of our experience at Hopkins were premature ejaculation and impotence. Impotence is far and away the commonest male disorder that we saw in our clinic. The definition of impotence is an inability to achieve or maintain an erection prior to ejaculation, which is sufficient for penetration and completion of the sexual act. Premature ejaculation may be defined as ejaculation during a process of foreplay, understood by both partners to be leading toward intercourse, may be ejaculation just before or during the act of penetration, or it may be ejaculation any time during the first 15 penile thrusts after intermission. I don't know that I've ever seen a case of premature ejaculation that I thought was primarily due to organic causes. On the other hand, I think I have certainly seen plenty of cases of impotence secondary to organic causes. So that whenever you see a patient who has impotence, you are obliged to be sure that you have ruled out possible organic etiologies. Functional impotence tends to be intermittent in its course, fluctuating in its presentation, and situationally dependent, whereas organic tends to much more often to be constant, progressive, and non-situational. But that allows you to infer, not to diagnose. Laboratory methods that are helpful in differentiating organic from psychogenic impotence. One of them is the nocturnal penile tumescence study, which may help separate the psychogenic from the organic. Another method is the penile blood pressure, in which one gets a penile brachial index, and then also one may take a look at the bulbocavernosus latency, which is the length of time it takes if you pull on the head of the penis, the length of time it takes to have what's referred to as an anal blink. That is, a contraction of the anal sphincter. If you pull on the head of the penis and it takes a long time to get the anal blink, then there may be some reflexogenic problem. And of course, one of the other things that you can do is that you can measure the testosterone levels in the blood. If the patient has less than 150 nanograms per deciliter, then testosterone administered parenterally might be useful. What you can see so frequently in the geriatric population is that if the men really are not sexually active, then they go out to date and to try to become sexually active again, and it's very common for there to be a period of impotence, and that can give rise to this kind of notion of use it or lose it. If you simply do nothing except talk with the patient about the loss of a spouse, what it was like, what it's like to try to date, how are things going, the impotence takes care of itself in about 6 months in 90% of the cases. Now, some technology has come along in the last 5 or 10 years that has taken us out of our dilemma of trying to determine the organicity or the psychogenicity of impotence by the presence of or absence of other factors which may contribute to it. Prior to the development of the NPT studies, we had no way to confirm that for sure unless we wanted to spend the night with the patient and photograph his penis every half hour or so. There certainly are patients who say, well, yes, I have morning erections, yes, I can masturbate to full erections, but there's got to be something physically wrong with me, doctor, because I cannot do it with my wife anymore. In that kind of situation, I think that one would go ahead and have nocturnal penile tumescence studies. The selection criteria for the NPT are the following: 6 months absence of or impairment of nocturnal and or morning erections by history. 6 months absence or impairment of coital or masturbatory erections by history, or the patient's insistence that the impotence is organic. The initial nocturnal penile tumescence studies that were done focused exclusively on circumferential changes. The problem with that is that one can get criterion levels of circumferential change in a penis without rigidity sufficient for penetration. So that the newer technology involves also the measurement of rigidity, and what you record is the buckling pressure. If a penis is able to withstand 500 grams of buckling pressure, one would consider that penis to be capable of achieving penetration and intromission. One of the reasons the nocturnal penile tumescence study is so important is that there is technology now to improve the situation in cases of organic impotence. The inflatable prosthesis is perhaps the most popular prosthesis at present for men who are suffering from organic impotence. It has a bulb, which is usually placed in the right scrotum. It has a reservoir, which is placed in the fascia of the rectus abdominalis muscles. And then it has tubes which connect that with expandable in circumference, not in length, expandable cylinders that fit into the corpora cavernosa. And in the flaccid state, the penis may appear quite normally limp so that no one would know a prosthesis was present. When the reservoir is pumped up, the cylinder expands and one gets the simulation of a normally erect penis. If the time is taken to acquaint the sexual partner with what the prosthesis really is, how it's going to work, how it may feel, then partner acceptance of the prosthesis tends to be quite high. If that time is not taken, partner acceptance of the prosthesis tends to be relatively low. Some of the kinds of things that you hear in the unprepared sort of situation, it feels like two sticks in a sack, it feels cold, I don't like it, where the women have been prepared to know that this is not going to be exactly like the kind of erection they knew about in the past. Being forewarned tends to improve the situation. There's a significant risk from hospitalization and being inactive. In terms of the surgery per se, the greatest complication is infection. If these foreign bodies get infected in the corpora cavernosa, they really have to come out because there's no way to clear up the infection once it's started without removing the foreign body. Some of the other kinds of postoperative complications are pain in the acute postoperative phase. A longer-term complication is intractable and continuous pain, which occurs for reasons that aren't quite clear. And then, of course, one of the long-term complications is partner dissatisfaction, that it really doesn't do, in terms of the particular sexual relationship, what it was hoped that it would do. The two other types of prostheses are much simpler, and so they have a somewhat lower, obviously a lower mechanical failure rate and have a somewhat lower morbidity in terms of the operation. The rigid device is simply a silicone rod, which is relatively rigid, that is put in the corpora cavernosa and adjusted according to size, and it gives the patient a permanent erection with all the attendant problems in terms of what do you do with your genitalia in your trousers and how do you manage to void. You have to, of course, bend over at the waist and those kinds of things. The semi-rigid has a silver wire coil through the core which allows it to be flexible, and you can, as the British say, dress your penis depending on where you want it in your trousers and put it there and it will stay there. One of the complications more so of these than of the inflatable device is what they call the SST deformity. You know, when the SST comes into land, the nose drops so that the pilot can see the runway and it comes down like a bird with a beak. If you get these of the wrong size or not adjusted properly, the glands in the distal portion of the penis drop off from the vertical and you look like an SST coming into land. Some comparison in terms of cost. The rigid and the semi-rigid are pretty cheap. It's about $250. The inflatable is around $1,600. They have to be carefully tailored to the length of the corpora and the length of the penis so that you don't get the SST deformity. In terms of cosmetic results, the cosmetic results are clearly better with the inflatable device. Postoperative complications: infection, perforation of the glands, pressure necrosis through the urethra, SST deformity, mechanical failure, paraphimosis, scrotal erosion because the pump is down in the scrotum, buckling of the glands. For whose sake is the implant being requested? Is it for the guy or or is it really for his sexual partner? I think it's mainly for the guys. They really do not feel adequate as men when they are unable to penetrate and to have penile vaginal intercourse with their spouses. Even though the spouses will often tell you, look, I understand he's getting old. We've worked out plenty of other ways that I can be happy and he seems to be happy. A man still wants it for his own self-esteem and pride, I think. The kind of criterion that I think is the important one is the residual capacity for erection that patient has available to him. If a patient can only get a 50% erection, some circumferential change, but almost no rigidity, and the erection is rubbery or floppy, penetration is very difficult, and it takes a lot of partner effort and patient effort, and it tends not to be too satisfactory. Beyond that, up around 70%, where there is some rigidity sufficient for penetration, then I would not recommend prosthesis. You can always have a prosthesis. You can't always take it out and go back to where you were. For selection, Peyronie's disease, they do suggest the semi-rigid. Quadriplegics with impaired manual dexterity and paraplegics with condom catheter drainage. That is an important point. If you have a patient in whom you have to catheterize or you have to do cystoscopy for whatever reason, you really cannot give that patient a rigid or semi-rigid device because the device will not allow the passage of the cystoscope, and it makes it difficult to pass a catheter, so that in that kind of situation you're better off with the inflatable. Sexual disorders can be classified as information lack, as interpersonally based disorders, as intrapsychically based disorders, and as organic ones. If you have an information or experience deficit disorder, then what the patient needs is information, brief counseling on his way to some experience. If you have an interpersonal habitual disorder, the kinds of techniques that tend to be designed to deal with this are your Masters and Johnson type techniques based in learning theory and perhaps certain kinds of psychoactive medication. If you have an intrapsychic disorder, the kinds of techniques that are designed to deal with this are your psychodynamic psychotherapies, including psychoanalysis in certain cases. The Masters and Johnson techniques are really predicated on the notion that there's no uninvolved partner, that the symptom is the disease itself, that the sexual partnership is the unit being treated, and so they would be more useful for the interpersonal habitual disorders. The assumptions of dynamic psychotherapy are that it doesn't matter who your partner is, that what's going on inside your head is conditioning the difficulties, that the sexual dysfunction is simply a symptom of something else. The question is, how do you tell? I don't believe that you can without taking a longitudinal developmental history. One can think about sexual syndromes in terms of pre-Oedipal syndromes versus Oedipal syndromes, and that they tend to broadly be divided according to loss or perversion of sexual function versus impairment of satisfaction. Pre-Oedipal syndromes tend to be the gender disorders, the paraphilias, and the primary impotences, and the Oedipal, such things as obsessional premature ejaculation and hysterical anorgasmia. The history does help you decide whether what you're dealing with in a particular patient is something that has more to do with what goes on with that particular sexual partner and the cues that they give each other about their sexual likes and dislikes, or whether the patient's problems has more to do with a long-term kind of developmental conflict that has been expressed and defended against in a variety of ways over the years. In the first case, the Masters and Johnson kinds of methodologies would be the treatment of choice, to my way of thinking. In the second, the psychodynamic methodology. The Masters and Johnson techniques are basically a systematic desensitization through a hierarchy of sexual assignments. The major premises of the Masters and Johnson is that there's physiological information is important. The basic assumptions of psychotherapy are that what goes on inside the head is most germane to treatment, not what goes on between two people. The prerequisites for dynamic psychotherapy, I think, have to do with are very simple at basis. a distress, a hope that things can be better, and a sense, however dim, that something internal makes things worse, rather than the notion that there's something inside of me that it's making a mess of this relationship, that it doesn't have to be that way. If a man is a premature ejaculator because he's got an obsessional neurosis and he is basically phobic about the vagina, then treating him with the Masters and Johnson techniques is not going to work. It's supposed to, but in my experience at least, it doesn't. The tools of psychotherapy, as distinct from the tools of the Masters and Johnson, are clarification and interpretation, basically. A marriage, for example, that was made for neurotic reasons, and then those reasons no longer pertain, that kind of marriage can break up. But the usual effect is that it strengthens the relationship. In other words, that the relationship was based on something more than neurotic reasons, and them removing the neurotic needs and demands placed on the relationship can only strengthen it. The fine points of methodology and skill have to do with expediting that process.
This concludes the remarks of Dr. Jon K. Meyer. Our program continues with Dr. Richard Green, Professor of Psychiatry and Psychology, Department of Psychiatry and Behavioral Science, State University of New York at Stony Brook Health Science Center. Editor-in-Chief of the Archives of Sexual Behavior, and author of over 100 professional publications. Dr. Green will discuss gender identity disorders.
Why is it that some boys become behaviorally feminine to the degree to which they now have what DSM-3 elegantly calls the gender identity disorder of childhood? And what about a substantial subsample of these boys, such that they evolve through childhood, adolescence, and into adulthood as homosexual or bisexual men? I define sexual identity as encompassing 3 developmental components, and the transsexual is atypical on all 3. To me, sexual identity includes, firstly, the self-awareness of being a male or a female. The second component of sexual identity is what psychologists usually call gender role behavior, sex typing, masculine behavior and feminine behavior. And the final ring on sexual identity is whether you are primarily or exclusively erotically attracted to people of the same sex or the other sex, or both. Both the male to female and the female to male transsexual have atypical sexual identity on all 3 parameters, and they report to us that the duration of their atypical identities as far back as they can remember. Now, at the time I began seeing these people, the immediate goal was whether they should have sex reassignment surgery. That's why they came to see me. To a certain degree, one must take the histories given by these patients with a grain of salt. Transsexuals utilize the psychiatrist as the gatekeeper to the surgical suite. Now, this is not to say that these histories have no merit to them. The questions, however, from a research standpoint, are just what went on 40 years ago, 45 years ago with this person to enable this degree of development. What the transsexuals do is provide for us, from their retrospective histories, a composite of people who, if they're behaving in the way these people recall their childhoods, ought to be on their way towards transsexualism. Harry Benjamin is the father of transsexualism. In 1966, he published a book, Transsexual Phenomenon. In the 1966 book, all the men who wanted to become women, or had become or were becoming women, all of them reported this lifelong cross-sex identity, always feeling that they were girls, wanting to do only girl-type things. There's not that much in common in adulthood between transsexuals and transvestites, but the most visible feature of boyhood cross-gender behavior, that is cross-dressing, overlaps between the two. Transvestites aren't anything like transsexuals in their pure form. In their pure form, transvestites don't want female hormones. Transvestites don't want sex change surgery. Transvestites are not sexually attracted to males. In fact, most of them are conventionally heterosexually married and have kids. But they like to cross-dress. Transvestites get sexually aroused by cross-dressing. Transsexuals don't. There's tremendous difference in what homosexual and heterosexual men report from their boyhoods. The extent of interest in boys' or girls' activities, gender-neutral activities, or cross-dressing. Being called a sissy, being a loner, having wanted to be a girl, playing with girls and cross-dressing, tremendous distinction on those 5 behavioral attributes between the homosexual and the heterosexual men. We initially thought, when we were looking at some of these, quote, feminine boys in the late 60s, that we were looking at pre-transsexual boys. As our study progressed, it became clear that if we were looking at any development of a pattern of atypical sexuality, it was probably homosexuality. The reason being that there are a hell of a lot more homosexual men in the world than there are transsexual men. We're talking about millions of bisexual and homosexual men. So if there is considerable overlap on the boyhood behaviors of these two groups, then probably they're going to be pre-homosexual men. Cross-dressing, disinterest in rough and tumble play, stated wish to be a girl, less desire to be like father, more attention to mother's fashions, and more interest in female-type doll play, perfectly discriminates, separates every feminine from every masculine boy in our sample. The follow-ups aren't complete, but we do have some very striking findings with respect to sexual orientation. There's something of a pattern being established. There's a substantially higher number of the previously feminine boys who are now in the bisexual to homosexual range, and essentially none in the contrast group. We have in our follow-up sample now, we have one transsexual who's 18, who is in fact hell-bent on becoming a woman, and we have one female impersonator. We have no transvestites. None of our men who currently cross-dress, and there's only really a handful that still do, experience sexual arousal to cross-dressing. But on the other hand, there is a substantial number of men who've emerged as homosexual or bisexual. Out there somewhere, 25% of all gay men went through boyhoods which were not distinguishable by being cross-gendered. Now, nobody's ever studied them developmentally because you don't know who to look for. Most of the so-called paraphilias are males. I mean, there's not more than 3 or 4 female fetishists ever described in the world's literature. How many women get sexually aroused by cross-dressing? But there are thousands of guys who cross-dress and get turned on. How many peeping Sallys are there? Peeping Toms, right? And pedophiles, how many people are women who get arrested for pedophilia? Most of the paraphilias are male. Now, again, you can argue them developmentally and psychoanalytically, or you can argue that there's a whole potential for something going wrong developmentally with males. The feminine boy syndrome, as an antecedent of homosexuality, is generalized worldwide. Homosexuality emerges independent of culture, and whatever it is that's cross-gender behavior in those cultures, that's there in the boyhoods of homosexual men.
This concludes the remarks of Dr. Richard Green. Please turn the cassette over for Dr. Maj-Britt Rosenbaum's discussion of female sexual dysfunctions. Our program continues with Dr. Maj-Britt Rosenbaum, Associate Clinical Professor, Albert Einstein College of Medicine, Department of Psychiatry, and Director of the Human Sexuality Center of the Long Island Jewish Hillside Medical Center. Dr. Rosenbaum will discuss female sexual dysfunctions after this brief message from SmithKline & French Laboratories. Serious medical complications and costly hospitalizations often are precipitated by patients' failure to follow the regimen prescribed by physicians for chronic diseases and various psychiatric disorders. In this statement from the September 1982 issue of Archives of Internal Medicine, Drs. Ron J. Anderson and Lynn M. Kirk focus on a problem of growing significance: patient compliance with suggested medical regimens.
Escalith CR, brand of lithium carbonate 450 milligram controlled release tablets, are designed to provide the efficacy, convenience, and comfort of BID administration, an important factor in increased patient compliance and successful treatment and prophylaxis of manic depressive illness. Escalith CR, 450 milligram controlled release tablets, when administered every 12 hours, gradually disintegrate, slowly releasing lithium without the initial rapid surge in blood levels seen with immediate release formulations. Escalith CR, 450 milligram controlled release tablets, offer physicians the option of twice-a-day dosing for optimum patient convenience, comfort, and compliance.
Lithium should generally not be given to patients with significant renal or cardiovascular disease, severe debilitation, dehydration, or sodium depletion, or to patients receiving diuretics. Lithium may cause fetal harm when administered to a pregnant woman and is not recommended in children under 12. Lithium toxicity is closely related to serum lithium levels and can occur at doses close to therapeutic levels. Facilities for prompt and accurate serum lithium determination should be available before treatment is begun. Patients should be cautioned about activities requiring alertness. Before prescribing Escalith CR, please consult the accompanying complete prescribing information including warnings, precautions, and adverse reactions. Now, here is Dr. Maj-Britt Rosenbaum speaking on female sexual dysfunctions.
What I have kept from psychodynamic and psychoanalytic thinking is the importance of sexuality in its broadest sense as the life energy, how it develops and expresses itself throughout life, how it remains really the bonding force, the glue between our own inner selves and our own past parts and relationships, as well as the ongoing important bonding that we have in terms of relating to others. Working in this area, one of the things that you have on your side is a very powerful ally, the pleasure principle, in the sense that you can directly bring about with some of the techniques a biological release where you have a pleasurable outcome, something which is very rare in most of our dealings clinically. Women can go through decades of actual sexual intercourse, rearing and bearing children, and never fully experiencing their bodily self in sexuality. Women have a longer time in terms of organizing or sort of more specifically coming to experience genital sexuality. It is much more clearly defined in boys as they grow up. This is how women present clinically. They come with a sense of not knowing about their sexuality, not owning it, not having a direct expression for it. A period in life that is very useful to go back to in discussing problems and getting histories, in understanding how a woman feels about herself, is the pubertal, prepubertal, adolescent period. It's a period that most of us remember. What comes across very, very strongly is that women have a tough time becoming comfortable with their bodily selves. There is innumerable women who really don't like their bodies. A girl with a rather generous breast development said, "My breasts look all right, but it somehow doesn't really feel like me. I have a feeling I need some time to grow into it." It's sort of the body's leading the way, and you catch up with it and start to feel comfortable with it. Same with female sexual expression quite often. It's kind of a sense of the psyche takes a long time to catch up. Girls will be able to tell you rather clearly, yes, there is the ovaries and the fallopian tubes and the vagina, etc., having very poor understanding of how this fits with the self. One of the things that I would ask them is, how big do you think your inner organs are? And a girl was 18 years old, very smart, and said, well, she thought that, the uterus may be sort of the size of a football, and maybe the ovaries were sort of maybe fist size or maybe a little bit smaller. This is not atypical. It's very hard to sort out this inner anatomy. It's rather confusing. It's diffuse. There's a poor kind of sense of how does it fit into the self. It's vague. Most vaginas nowadays will be brought into our psychic awareness through menstruation, through the use of tampons, a very different entry into one's sexuality than pleasure or sexual experience. And it takes many years to sort this out. The one part of the female genitalia that are visible, the vulvar structures, the labia, etc., they're never talked about in most sex education courses. In one sample of 30 girls I talked to, I think one of them mentioned the clitoris as a sexual organ. It's not integrated. Contrast this in your mind with the male genitalia. they get touched, stimulated. You have to have massive repression not to know that this is a sensitive organ that will behave in a certain way if it gets touched or you have a fantasy. It's a very different experience that many girls have. Normal development tends to have a different kind of an unfolding because it depends so much on other feedback. The immediate biofeedback of the body in the male is not there in women. She has to rely on just the senses from the body, on intellectual knowledge, much more than her male counterpart. Lately, she has started masturbating more. Certainly one of the most effective social, biological, biofeedback mechanisms that young boys have. Over and over again, they will experience their body in sexual excitement and release. And it starts being organized and understood, and it's something that's part of their body. More girls are masturbating, still much less so than boys. And even the ones who do tend to do it less frequently. You ask the boys, have you ever been horny? They know exactly what you mean. Ask the girls, many of them say, I'm not sure that I ever really have. A little bit older, especially the ones who have masturbated, say, yes, I get horny. Then you ask, well, how does it feel? It is rare to get an adolescent or a young woman without sexual experience to describe, I have a sense of genital feelings and some sensation of wanting to have sex. It's very rarely focused genitally. If you then ask more directly, do you ever have any feelings genitally, or you say, yes, but it is not unusual to get the kind of feeling of relationships and touching and bodily sensuality. It has a very different, diffuse quality. What starts happening again around midlife is coming closer. The sense of the two sexes needing each other to organize their full sense of themselves as sexual beings. What's striking in terms of seeing female sexuality unfold is really the need of the organizing force of male sexuality, which has a different developmental feel. So much of how women feel about themselves sexually comes very strongly in relation to men. Rather frequently, women's sexual awakening comes in an interpersonal relationship, in terms of petting, being touched, kissing, feeling those feelings come up. They do so with boys too, but it tends to be initially more genitally focused. As there is more of a meeting of the streams, the fit gets better. Milestones and natural organizers tend to be moments where we developmentally move forward or not. First menstruation tends to be more important before a girl has the menstruation. Once she has attained it, it tends to be rather easily assimilated and integrated. One of the major organizing points right now has to do with virginity. It used to be much easier when the rules were clearer. Now there's a lot of conflict around this. Some of them will say, I hope that I will have the experience soon. I'm not sure I'm quite ready. I have a feeling it will be very important. That sense of losing one's virginity still has an important sense of maybe I will get in touch with something more deeply about myself, be more completely me. Worth asking about. One of the sad parts about it is that it's often not that great an experience. The girl who is in a good, affectionate, loving relationship will remember it rather fondly as something that was important. But it often does not give that immediate biofeedback of a pleasurable experience. Just the simple contrast with a young boy who has his first sexual experience. He can be clumsy, miserable, premature ejaculate before he even gets in. He will have a bodily positive experience to mark it. For the girl, it's often, fraught with a fair amount of both positive and negative anticipation. It may not be physically a pleasurable experience. It very often is psychologically, psycho-emotionally a positive experience. I see it as really, it's an organizer in terms of the sense of self and in terms of the sense of sexuality. It can be a critical point. One of the other very important kinds of things to keep in mind is contraception. This is another important rite of passage for women, more so than for young men. It's a big step. Internally and in terms of deciding both ethical and self issues. And we know how poorly it is used, how the active use of contraception means an active acceptance of a sexual being. Then comes the fairly frequent possibility of becoming pregnant. Today you can have an abortion. An abortion has a scarring quality and wounding quality on one's inner sense of sexuality. There's a lot of inner conflict about this. They say, of course abortion should be available. And yet, how can I do this? How can I be the one to kill something? It can come back to haunt you. I've seen women who've moved from heterosexual experiences into periods of gay relationships, away from sexuality after having experiences. Even the ones who sail through it and it seems fine, well, when they become pregnant later on, worry. The constant interplay of the reproductive aspects of sexuality. One should never, ever, ever forget, even in terms of having effective contraception. Intercourse in some part of women's psyche is involved with the possibility of pregnancy. The same kind of feeling about reproduction and mothering and pregnancy, especially in the early years, have a great deal of influence on how a woman reacts. The inner, more unconscious fears and wishes for pregnancy. Ask any adolescent girl, and they have rehearsed pregnancy in their mind. As women move, through these years and through adolescence, the critical points tend to be around issues that have to do with both bodily changes and commitments. Where we see the sexual dysfunctions surface are at points of committing oneself to living together, getting married, having or not having a first child, what happens through pregnancy, the inner changes in terms of a woman's feeling about herself and her partner. And at each stage, inner old experiences come into play. Orgasm tends to become more important. Many women will go through years of sexual experience without experiencing orgasm, especially not in intercourse. It's a learning experience, and it's getting enough of the stimuli together into a reflex action that will release. And it varies from woman to woman. There's more of a learning experiential feedback mechanisms that has to go on with women. And it tends to be harder to get all the parts together. I see woman after woman who will come in after years of marriage. She's never experienced orgasm, but she's been fine until some other critical issue has raised this, higher up kind of in the psychic economy and made it a painful area. There are many women who have experienced or do experience physiological orgasms and have not attached the other emotional, psychological meanings to it. Women will experience orgasm with a variety of techniques that you can directly stimulate the nerve endings, and it still doesn't have the quality of it. What is the orgastic experience, and what are we talking about here? On one level, it is a neuromuscular reflex dependent on all that functioning well, and very rarely does organic difficulty interfere with female functioning. And female dysfunctions tend to have a quality of not having become integrated, whereas the male problems come in terms of performance spheres. For women, it's, I am not getting pleasure. I am not experiencing what I think I should experience. The orgastic experience depends on just listening to the body, being able to interpret the muscular contractions as pleasurable. The reflex may have been triggered, but it has not been interpreted and labeled as such. It's a rather complicated reflex to integrate with fantasy and expectations and memory. something that we often tend to not take into account as much when we talk about love and sexuality, etc. Aggression. It's often an important component, both in terms of the activity and assertiveness of a woman and her own feelings, wishes, and needs, and the dealing with what is sensed as aggressive, intrusive demands and needs of her partners. So frequently, it's the withheld aggressions, the negative feelings, the fears that will block the flow of sexual expression. A lot of the sexual excitement has to do with the intermingling, with the overcoming aggression often comes into play. Women have a much harder time acknowledging or even being in touch with any active, aggressive, I want to take part in it. It's one of the things that often comes up in therapy in terms of take a step, do something. Also talking about something that tends to be more uniquely female experiences are the cultural fears as well as real experiences of rape, early experiences of overstimulation, even if it doesn't have full sexual expression, the repeated historical evidence of incestuous behavior. It can, as a very real experience, inhibit sexuality. The kind of impact that that has on her sense of herself and her sexuality and how she can express it can have really lifelong repercussions and has to be dealt with rather directly. The sense of the helpless victim role can be deeply, deeply embedded. The many ways that the sexual drive can be dealt with, and to be able to get the sexual feelings together with loving feelings is one of the kind of challenges of dealing with female sexuality. In order to be able to share ourselves sexually with another person, a very complex, rich way of sharing, expressing, communicating that has many variables to it. You cannot share something until you own it yourself. And one of the over and over experiences that comes up, is owning, feeling comfortable with knowing how to feel about the self, how to express it to the other, and how this meshes, and how to come to grips with what that particular other is for a woman. Takes a bit longer because culturally she's focused on the other more than on herself. A good half of the cases we see will fall into desire-type disorders. It doesn't feel right. The desire level is different from the partners. They've never really felt themselves in touch with their sexuality. A small group, 10%, have a variety of pain syndromes. It is one of the sort of red flags that should go off somewhere in your clinical minds and say, let me get a consultation. Small difficulties can mushroom into phobic defensive symptoms that can be very difficult to treat. So take pain seriously and not initially poo-poo it as a psychogenic symptom. A group of women that will come in as they enter sexual relationships have not been able to experience orgasm. These will respond very well to the many group treatment approaches, to reading books. There are many, many women who will be helped reaching orgasm and getting in touch with their sexual selves by just reading. Are there deeper causes? A lot of difficulties in connecting, in aggression, in fighting, and mutual nurturance. Once you get the picture of not owning any of the problem, owning any of the pathology or the difficulty, you know that you have a long haul ahead of you, that we're really dealing with much deeper psychopathology in terms of character structure that is formed. So to determine how severe these causes are is one of the kind of major biopsies that you do rather early on. What are the relationship factors? Does it run parallel with the relationship? Is it something that stands in the way? Is it a symbolic expression of what goes on between two partners? Very often something like premature ejaculation in a man, lack of orgasm in a woman, can be a symptom that is really not part and parcel of the relationship per se. You can have a loving relationship where this particular symptom can become very disruptive and destroy the relationship. In others, the very sexual problem is part and parcel of the relationship, almost symbolically represents a power struggle. A variety of issues that are played out in the sexual scenario. It's so important to really get in your own mind a very good video picture, in a sense, of what happens in the sexual interaction. Ask about their best sexual encounter, then ask about a negative one. Focus on the positive, on what works for them. In a sense, you already start doing therapy while you're taking the history. The other basic tenet of sex therapy is that you don't teach anybody to have sex. That's a natural function. What we keep doing is trying to remove the roadblocks, provide experiences for learning. It's not directly teaching. It's an uncovering, an unfolding of what is already there. One of the sine qua nons of sex therapy are these prescriptions, the little experiential behavioral task situations that you will prescribe to the patients. There is sort of a cookbook of them available, the sensate focus exercises. I'd urge you to use them. When you have a couple who has any kind of difficulties with sexuality or intimacy, it often means giving a task in terms of go out to dinner, take a walk, spend some time touching in other areas, do more affectionate hugging and kissing. One of the nicer aspects of focusing on therapy this way is that you focus on the pleasurable. Use interpretation in a different way than when you would just do psychodynamic therapy and try to explore. You will use it as information, as education, as a way of understanding more. One of the probably most important things that goes on in the therapy is defining it. The main problem is to share that and having a shared problem defined for a couple. Crucially important when you deal with couples. You can do a lot with single women. Quite often, in getting the pre-orgasmic women, a lot of really kind of exciting therapy can be done with women alone in the direct sexual arena. And one very powerful question that you can really ask a couple or a woman when she comes in is, do you love your husband? Because you can do a lot of teaching and educating around how one expresses love. Often in dysfunctional couples, you will hear, life is absolutely miserable and we fight all the time, but we really love each other. What is meant by that is can be a very powerful therapeutic issue. Loving it's only an affective state, but the important part is the active expression of it. There's no way anybody will know that you love unless you say it, show some expression, and that certainly comes up in sexual kind of relationships, and that can be good with very disturbed, distorted relationships. What will come out of doing therapy and what remains with the couples is a sense of I feel better about myself and better about the relationship, and there's better communication. The main effect has been an increased relaxation and sort of good feelings about each other and the relationship. It's one of the few positive things we can offer and really actively work with. Not just relieving anxiety, but adding something that has positive energy to it.
This concludes our program on eating and sexual disorders, featuring Doctors Jon K. Meyer, Richard Green, and Maj-Britt Rosenbaum. This program was recorded on location at the 6th Annual Vail Conference of the Menninger Foundation. SmithKline & French Laboratories sincerely appreciates the cooperation of the Menninger Foundation in the production of this continuing medical education program. The views expressed here are those of the individual physicians. Their participation is not intended as an endorsement of SK&F products. It should not be inferred nor assumed that the participants are expressing the views of SmithKline & French Laboratories or any other manufacturer of pharmaceuticals mentioned. This program was produced by SmithKline & French Laboratories and SK&F Co.